Welcome to the presentation from Module 5 for Nursing 150. This presentation is going to discuss lower intestinal inflammatory disorders. Appendicitis is an acute inflammation of the vermiform appendix. Typically, it occurs among young adults. It's the most common cause of right lower quadrant pain. The appendix can be found extending off the proximal cecum of the large intestine, just below the ileocecal valve, which is the ileum, where the ileum from the small intestine meets the large intestine. This inflammation usually occurs when that appendix gets a collection of food or undigested food in there, and it gets obstructed. If it gets blocked in there, it can lead to an infection because a buildup of bacteria can occur from the buildup of the undigested food in there. It can also be a buildup of hard pieces of feces. It can be a calcium buildup in there. Less common causes are malignant tumors or other infections. When this gets blocked, it can be infected, which results in pain. The complication that can arise from this infection is the fact that the appendix can actually burst, and that can be a serious situation due to, if it bursts and it results in the infection being introduced into the entire peritoneal cavity, which can cause a peritonitis, which is an infection of the peritoneal cavity. Can be life-threatening, can lead to gangrene and sepsis within 24 to 36 hours. So important to identify a burst in appendix. And typically that patient will become more sick. Their pain will increase, their temperature will rise, and it will cause an increase in their heart rate. So it's a person that's admitted with perhaps an appendicitis that becomes more and more acutely ill. You would suspect that they have a perforation of their appendix. Appendicitis perforation is more common in older people, and this can be very life-threatening in older people. Signs and symptoms of appendicitis are an abdominal pain along with some nausea and vomiting. And it's that classic cramp-like pain, epigastric or periumbilical area, that means around the umbilicus. They will have a poor appetite, nausea and vomiting. And then assess for that abdominal pain. As the inflammation and infection progress, the pain becomes more severe. That right lower quadrant pain will be much more obvious. And there's a point where you can assess for appendicitis. It's McBurney's point. And there's a picture of McBurney's point on the next slide, but essentially it's located between the anterior iliac crest and the umbilicus in the right lower quadrant. Typically they do like a little rebounding tenderness. When you push in, it doesn't hurt. When you release your hand at McBurney's point, the pain intensifies. Patient will also present with pain that increases with cough. It's relieved by laying and bending the right knee up, and that can indicate if they're presenting with that kind of pain, then you would suspect that they might have a peritonitis. So basically, if the pain is relieved by them bending up their right hip or knees. This is a picture of McBurney's point, and that's just because the McBurney's point is determined as right near where the appendix is, as you can see here. If you press on this area, it doesn't hurt, but when you release it, it's called a rebound pain. That would indicate when there's increased pain with release of pressure, that would indicate an appendicitis. It's important to remove the appendix when the patient has appendicitis. Typically they do just remove it before it can burst, An appendectomy is a removal of the inflamed appendix. It needs to be done pretty soon after somebody develops an appendicitis, due to the fact that we want to prevent that appendix from bursting. Post-op care of this patient is going to be monitoring the dressing, monitoring the side. It's going to be pain management, and then monitoring them to make sure that they can start their PO intake. Antibiotics are probably going to be given just prophylactically to prevent them from having any infection related to the hospitalization and the surgery. Activity usually returns to normal in 4 to 6 weeks. Gastroenteritis is essentially just an inflammation of the mucous membranes of the stomach and the intestinal tract. Typically, it's viral. It's basically like your viral bug that you get, where it causes nausea, vomiting, diarrhea for a couple of days. Some of the most common bacteria or viruses that causes gastroenteritis is norovirus is a common one. Epidemic viral. You can have E. coli is a bacteria that causes gastroenteritis. Norovirus is the leading foodborne disease that causes gastroenteritis. It typically occurs between November and April, and that's due to the temperature and the climate. In most cases of gastroenteritis, the illness is self-limiting and lasts about 3 days. If a patient is already immunocompromised, in older adults or small children, the dehydration is what can cause complications because they are easily dehydrated. At times they have to be hospitalized to have fluid replacement due to the persistent nausea, vomiting, and diarrhea. Care of this patient would include monitoring for signs and symptoms of dehydration, that skin turgor, dry mucous membranes, hypotension, low urine output. They can experience orthostatic blood pressure changes. They can have a fever, which could complicate the dehydration as well. If the dehydration is severe, they will need to be hospitalized at times. In the older adult, dehydration can lead to mental status changes, acute confusion. So just monitor them and manage that. Encourage fluid replacement, Pedialytes, Gatorades, Powerades. If you can get that down them, it could be IV fluids in some cases. There are antidiarrheal medications that are often not recommended in these cases. If it's a bacterial cause for the gastroenteritis, the patient needs to expel this out of their system, so taking an antidiarrheal would not be indicated here. There are some gastroenteritises that require a antibiotic, and that would be we would have to get a stool sample and do a culture to determine what's the cause of the gastroenteritis. If we determine that it's a bacteria that requires an antibiotic, that would be indicated. Education on preventing the transmission of this to other people would be warranted as well. It's washing your hands, just basically quarantining the patient, keeping them directed to one restroom only, and just staying away from other people and not sharing items. You're going to make sure that you clean that bathroom after the person is feeling better, and make sure you throw away, maybe some of the toothbrushes and stuff in that room as well. We're going to begin to talk about chronic inflammatory bowel disease, ulcerative colitis versus Crohn's disease. You're going to find that they are very similar in presentation and often difficult to confirm which is which. There is a table in your book that differential features of ulcerative colitis and Crohn's disease. I encourage you to look at that table, kind of to compare and contrast the two. And typically it's they are very similar, but it's the affected areas in the colon that distinguish it from one another. The other thing is Crohn's disease is more common for fistulas, and we'll talk about that as we talk about Crohn's disease. Often, ulcerative colitis causes more liquid stools during the day than does Crohn's disease. So we'll talk about that a little bit. We'll begin with ulcerative colitis. It's usually inflammation of the colon. Usually, it occurs in the lower part of the colon, the rectum, and the rectosigmoid colon. It can extend further, but one of the major characteristics of it is that it begins in the rectum, in the rectosigmoid colon. It does tend to occur in younger patients, age 15 to 25, when it's first diagnosed. It does have periods of remissions and exacerbations. It is thought to have some autoimmune causes. It does seem to run in families as well. Patients who have other autoimmune diseases such as lupus, gout, they tend to be patients who will develop ulcerative colitis as well. Patients will have multiple episodes of loose bowels on a daily basis. Severe ulcerative colitis is typically considered greater than 6 stools a day, and they can actually become bloody, and it's just because of the inflammation that occurs in the bowel. They can have stools with blood and mucus. This can lead to dehydration, anorexia, weight loss, lots of complications that can occur related to ulcerative colitis. Patient will at times develop fevers related to the inflammation in the colon. And these are patients that we would have to determine this is not just a viral gastroenteritis. These people have a chronic diarrhea. So they would have to be worked up for a more chronic situation if they're having daily loose bowels. These people can develop an anemia, so checking a CBC would be indicated. An ESR, C-reactive protein, those would indicate inflammation that's present. They might develop electrolyte imbalances or fluid and electrolyte imbalances due to the diarrhea. Colonoscopy is going to be the most diagnostic tool that will aid in the diagnosis, and that's just taking the scope and looking at the actual bowel where they can see the inflammation to determine if the ulcerative colitis is present. Management of ulcerative colitis. Typically, surgery is not indicated unless someone has developed an obstruction or from an extended inflammation, or that they've had a perforated bowel related to the inflammation as well. But typically it can be managed non-surgically. The goal here is to decrease the amount of diarrhea and manage the diarrhea with these patients and decrease inflammation so that they don't have diarrhea, because we know that extended periods of diarrhea is going to lead to weight loss and poor fluid and electrolyte balance. Nutrition therapy is where we start. Make sure they're getting enough fluids and make sure they're getting enough quality fluids to maintain their fluid and electrolyte balance. They're going to monitor their stools, make sure that they record how many they're having per day, have the patient weigh themselves to determine how much weight loss they're having. Common drug therapy for ulcerative colitis is glucocorticoids, antidiarrheal medications. Glucocorticoids are going to decrease the inflammation. Those are drugs such as prednisone. Immunomodulators are going to alter the person's immune response. Those medications consist of infliximab, which is Remicade, adalimumab, which is Humira, is the brand name of that. Those are can be infusions that are given intermittently. They are expensive drugs, but they are very effective for the treatment of both ulcerative colitis and Crohn's disease. Both of these, the glucocorticoids and the immunomodulators, are going to put the patient at risk for infection. They're going to need to stay away from crowds, wash their hands, and stay away from people who are sick. Typically, nutrition therapy and rest is required for these patients when they're having exacerbation. They need to make sure they maintain their rest, proper rest. Diet, alcohol, and raw vegetables and caffeine tend to exacerbate their symptoms. Lactose-containing foods sometimes are poorly tolerated, so they basically need to keep track of any kind of foods that seem to exacerbate it and avoid it. Again, it's typically like smoking is another one that can cause it, caffeine, alcohol, raw fruits and vegetables at times can cause GI symptoms. Especially during exacerbation, they would want to avoid these foods. Moving on to Crohn's disease, it is a chronic inflammatory disease of the small intestine more often. So that's the difference as far as the difference between Crohn's disease and ulcerative colitis. As you recall, ulcerative colitis essentially is talking about the colon, the large intestine. The Crohn's disease more often affects the small intestine. It can affect the GI tract from the mouth to the anus, but again, it's most commonly found in the small intestine. It's an unpredictable disease thought to be autoimmune, causes not clearly understood, but it is thought to be an autoimmune disease. It is often found in patients who have other autoimmune diseases such as lupus or gout. It tends to be a familial tendency as well. It does tend to run in families. Other risk factors for Crohn's disease tends to be tobacco use, Jewish ethnicity, and people living in urban areas. The inflammation in Crohn's disease causes a thickened bowel wall, and it also causes strictures and deep ulcerations. And that's a significant difference between Crohn's disease and ulcerative colitis is the deep fissures that's caused. And these deep fissures and strictures and deep ulcerations can cause fistulas, which means an abnormal opening between two organs, and that can cause major complications. Severe diarrhea develops also from Crohn's disease, and of course they end up anemic and fluid and electrolyte imbalances as well. Complications are similar to those of ulcerative colitis. They can develop severe malnutrition. They can develop bleeding, obstruction that may lead to surgery. The fistulas usually require surgical intervention. They can develop scarring along their intestinal tract, which can lead to bowel obstructions and just an obstruction in the flow and peristalsis. You need to be on alert with these patients to make sure that they do not develop signs and symptoms of a peritonitis, which could be due to a bowel perforation. That means the bowel gets so inflamed and it actually perforates or busts open essentially and allows the content of the GI tract to be introduced into the peritoneal cavity, which causes a peritonitis, which can be a life-threatening situation. Obstructions basically is just where there is something obstructing the flow of peristalsis through the GI tract, which can also be a life-threatening situation. This is a slide that provides a visual between the affected areas for Crohn's disease and ulcerative colitis. Like I said, this is the area that's typically affected by ulcerative colitis, and then Crohn's disease can develop anywhere along the GI tract, but typically the small bowel is where it manifests. A few other differences between the two to compare and contrast. Again, these are the fissures or the deep ulcerations that I was talking about. And this is where if another part of the bowel is coming along here, the fissures can develop an opening between the two. So if this is a small intestine, you know how the small intestine is kind of curled up on itself. It can add an abnormal opening there, which can develop infections and peritonitis. These are the more what more of an ulcerative colitis looks like. It's not as deep fissures. It's just essentially like an inflamed area in the large intestine. Treatment for Crohn's disease is essentially the same as ulcerative colitis. It's basically treating them with antidiarrheals, anti-inflammatory medications such as prednisone. They also will be on the immunomodulators such as Remicade or Humira. Remicade is typically given in a doctor's office or in a healthcare setting. It's an infusion. Adalimumab, which is Humira, can be given subcutaneously. So the patients would be taught how to give them to monitor for any injection site issues. They need to avoid crowds as well and avoid people with infection. They're very effective medications for ulcerative colitis and Crohn's disease, but they do make the patient immunocompromised, and then also they're expensive drugs as well, so that can sometimes be a barrier. Metronidazole is also a medication, which is flagyl. It's an antibiotic. At times is indicated if they appear to have an infection in their GI tract. Nutritional therapy, again, they can develop malabsorption issues. We have to monitor to make sure they're getting enough fluid intake, enough dietary intake, and make sure they stay away from foods that can exacerbate their symptoms. Stress seems to exacerbate Crohn's disease for sure, sometimes ulcerative colitis. So they need to be able to kind of have a way of decreasing the stress in their life. And then monitoring for complications of these two is very important. It's important to be aware of the fact that they can develop a peritonitis, they can develop fistulas with Crohn's disease specifically, and they can develop poor nutrition, dehydration. So the job as the healthcare worker is to understand that the patient has a history of one of these inflammatory bowel issues, these chronic inflammatory bowel issues, and monitor them for complications. The other thing I want to point out, at times Crohn's disease or ulcerative colitis, a lot of times it's more the Crohn's disease that requires surgical intervention. If they develop a peritonitis, if they develop a obstructed bowel, or perhaps an area of fistula, they might need surgical intervention to remove that part of the bowel that is affected, and they might require an ostomy or a stoma. So it's important to understand that these patients would require that treatment and that nursing teaching after such a surgery. So be sure to review the presentation from the wound ostomy nurse regarding care of a patient who has a stoma. These are questions to assess your learning regarding inflammatory issues of the lower GI tract. I encourage you to try to answer them and find the answer in the comment section of the PowerPoint. And this concludes the presentation for inflammatory disorders of the lower GI tract for Module 5 for Nursing 150.